Hi, my name is Dr. Jerry Bagel from the Psoriasis Treatment Center of Central New Jersey at Windsor Dermatology in East Windsor, New Jersey. Welcome to this educational activity on scalp psoriasis.
The following podcast is part of a certified educational activity titled Addressing Unmet Needs in Scalp Psoriasis, a closer look at current management strategies and the clinical potential of new therapeutic options. Access the entire activity and complete the post-test at www.peerview.com/DNF. Downloadable infographics and additional resources are also available.
As we have learned over the past 2 decades, psoriasis is an immune-mediated inflammatory disease. Typically, from a clinical perspective, we see plaques that are perceived as erythematous, raised, infiltrative, scaly, red, inflammatory lesions with a silvery buildup of the stratum corneum, silvery white areas that commonly manifest itself on various parts of the body. Although the trunk and the extremities are the most commonly affected areas, the scalp, the face, the nails, palms, soles, and intertriginous areas, when effective, have an intense impact on the quality of life of these individuals. So, in focusing on scalp psoriasis, we know that at least half of our patients that have psoriasis have scalp psoriasis. And sometimes that is the major feature of their psoriasis. Many times I see patients that come in and their scalp is covered, or 50% of their scalp is covered with thick, scaly, erythematous plaques, and they have very little psoriasis or sometimes none on the rest of their body. And when we look at scalp psoriasis, sometimes if it's mild, it could be misdiagnosed as seborrheic dermatitis. Sometimes you need to consider tinea capitis in the differential diagnosis. But unlike the other two, you tend to get silvery scales that are very adherent to the scalp, which is something you don't necessarily see in seborrheic dermatitis. And also, when you remove some of the scale, you get what we know as the Auschwitz sign, where there's going to be blood noted that is specific for psoriasis. In addition, scalp psoriasis is extremely pruritic, itching, and keeps people up at night because they can't stop scratching because of the severe itching, and then they don't sleep, and there's a fatigue effect. And as we know, Kebnerization, which was defined by Dr. Kebner in Berlin in the 1860s, who noticed an increased frequency of psoriasis on the inner aspects of horseback riders' legs. Now we know that trauma induces psoriasis. So by scratching, brushing, picking, any type of trauma induces the psoriasis on the scalp to get worse. The scratching, which may feel better, actually promotes more psoriasis and ultimately may result in hair loss. If you're a woman, you're not going to wear a black dress. And if you're a guy, you're probably not going to wear a navy blue suit. When you start trying to use topical therapy in the scalp, where there's a lot of hair, it's very difficult to get scalp treatment effective with topical therapy because of compliance. And people tend to use it more as a hair product when they use topicals. So it's difficult to use topical therapy in the scalp. We know by doing patient-reported outcome quality of life measures that people with scalp psoriasis, 70% of them say it has a major impact in their quality of life. They're ashamed, embarrassed. I mean, think of yourself as being in a dorm and going to the mirror with other people, and all of a sudden you have red scaly plaques around the surface perimeter of your scalp. And people don't know what that is. They don't know if it's contagious. They don't know what it is. And it really makes you very anxious and self-aware and ashamed. And that decreases your self-esteem, increases risks of depression and anxiety. When we look at psoriasis as a total disorder, when we try to assess the gravity, of the disease, we look at the body surface area involvement. The patient's palm is equal to 1% of the body surface. So 100 palms would be 100%. If it's less than 3%, it's considered mild. If there's 3% to 10%, it's considered moderate. And if it's greater than 10%, it's considered severe. However, I don't think that can always be the guidelines for severity, because let's say you have psoriasis on your feet and it's extensive. Well, by definition, that might be 3%, which would be mild. But if it's bleeding and cracking and you can't stand at work, then it's severe. Ditto with the hands and with the scalp, which it could be 3-4% of your body. If it's major impact that you can't sleep, that you're very self-conscious, that it's always red and inflamed, even though it's less than 3%, it's still severe. If somebody has severe scalp psoriasis and has not responded to topical therapy, which we'll get into a little bit later, I'm very quick to go to a more aggressive type of treatment, such as a biologic therapy. Now, how severe does scalp psoriasis have to be to consider severe? And some of the consensus is greater than 50% of the scalp. I don't know if that's necessarily true, and maybe that's this consensus, but I know in clinical trials, it's usually greater than 30% when we start evaluating scalp psoriasis, but they also have to have at least some degree of significant, I will say, erythema, scaling, and induration. Now, the treatment guidelines for psoriasis, which is from 2008 and will be updated this year, basically divides it into two camps: psoriatic arthritis and non-psoriatic arthritis. If you have psoriatic arthritis, you'll go to either systemic or biologic therapy. And if you have psoriasis without psoriatic arthritis, it depends on if you have mild, which will be topical or maybe localized phototherapy, or if you have moderate to severe, then you would use phototherapy, oral systemic, or biologic. The topical treatment options for psoriasis, topical steroids, are very strong and quick acting, but you can't use for a very long period of time because of potential stria, hypopigmentation, and atrophy of the skin. Calcipotriene, vitamin D derivatives, usually ointments that can be creams or foams, which work somewhat but very slow and tend to work best in combination with topical steroids. Tazarotene, the topical retinoid, which has some benefit but does irritate the skin. Coal tar, which has been used as an old treatment for 100 years already in combination with UVB. I wouldn't use it unless it's in UVB, but it is used in some scalp shampoos with some benefit. And calcineurin inhibitors, which are non-steroidal immunomodulators, are best used in areas where you would not want to use steroids, such as face or intertriginous areas. Now, in considering the use of topical therapy for scalp, obviously the things that are very important are the vehicle, because if the patient isn't going to like the vehicle, they're not going to use it. If it's sticky, if it's greasy, if it's hard to get out of your scalp, they're not going to use it. Even if it works, it's too much effort. People are not going to use it if it's too oily. So it's a combination of the vehicle and the product, the medicine. And the medicines that seem to work best are the super potent topical steroids. And in this study that we did with the desoxymethasone topical spray, we can see that the psoriasis scalp severity index, which is like a PASI for the scalp, which was started at 27, which is somebody that might have had about 35-40% of their scalp involved with moderate erythema, induration, and scale, maybe a little bit more than moderate. And it went down by 80% in 4 weeks. But then once you stopped, you lost about 30%, so you're at about 60% better. So you're having some benefit here with topical therapy, but you don't keep that dramatic response once you stop treatment. And if you look at patient-reported outcomes, you also see that the biggest benefit was in scaling, improvement by about 75% at week 4, and then it drops to about 56% at week 16. and also itch, which was 62% improved by week 4, but then only 45% by week 16. So some benefit is maintained. So the question is when to initiate systemic or biologic therapy. And to me, it basically is if topical therapy doesn't work, if phototherapy is not appropriate, then I think one should consider systemic or biologic therapy. So there have been many studies that have looked at various biologic agents in the treatment of scalp psoriasis. In the study here for scalp psoriasis, etanercept was utilized 50 milligrams twice a week for 12 weeks, and then dropped down to 50 milligrams once a week for 12 weeks in the first cohort. The second cohort received placebo for the first 12 weeks, and then did etanercept 50 milligrams for twice a week for the next 12 weeks. So that was a randomized placebo-controlled study. And what they saw was an 87% improvement in the scalp psoriasis index within 12 weeks, compared to 20% in the placebo, and that the PASI 75 improvement was 86%. And actually, over the next 24 weeks, even though it was stepped down to once a week, it went up to 91%. So this was really one of the first biologic agents that showed significant scalp improvement, even better than etanercept tends to do on the body. Then came along adalimumab, and in these studies that to me don't seem to be as, specific and randomized placebo-controlled, there was a significant improvement in scalp psoriasis using adalimumab over a 16-week period. And when you start comparing some of the older biologic agents, etanercept, adalimumab, ustekinumab, and infliximab, you start seeing that in the Scalp Psoriasis Severity Index 75, over 12 weeks, etanercept's working pretty well in this study, adalimumab pretty well, and you start getting some better responses with ustekinumab and infliximab, which tend to maintain their efficacy over a year. And it tends to reflect in these studies the efficacy overall of these biologics on the rest of the body. In the more recent few years, we've been utilizing newer biologic agents, interleukin-17 monoclonal antibodies. The first one I'd like to discuss is secukinumab. And with secukinumab, which is administered 300 milligrams at week 0, 1, 2, 3, and 4, and then every 4 weeks, you see that there is a quite quick improvement of the scalp psoriasis in this study, so that you can see here that you're getting about a 90% improvement in about 55% of patients. You're getting about 55 to 60% of people that have 90% improvement in the 24-week period, and it continues to improve if you keep looking at the slope. And you have almost 50% of the people that are clear. In regards to ixekizumab, in the phase 3 study, the PSSI 90 was in the 80% range, and that was compared head-to-head with etanercept, which was at a 56% range. And actually, somewhere between 69 and 75% had a PSSI of 100. The oral medication that's been around for about 5 years is apremilast. Apremilast is administered 30 milligrams BID, and many patients like it because it's not a shot. And what you could see here is that the response of people achieving clear or almost clear within a 16-week period is 46% in one study and 40% in the other. So, well over 2 out of 5 people within 16 weeks might want to try, for this efficacy, might want to try a pill first. The main thing I want to say in conclusion is that I see many patients that come in with scalp psoriasis. And many of them come in with a bag of medicines. They're so frustrated. Some of the medicines were for seborrheic dermatitis. Some of them are shampoos. But some of them are good medicines. But it didn't work. It didn't work partially because they weren't compliant with it. And they've also seen 3 dermatologists. And if you want to be the 4th, but not the last, and give them another topical therapy. Because by the time they've tried a few, you can be sure the next one is probably not going to work. So I really jumped to a biologic agent then, and I've had remarkably good success and remarkably happy individuals. I never underestimate the impact scalp psoriasis has on an individual. And so therefore, I'm not just going to cavalierly treat them with topical therapy and tell them to go on their way, knowing that in most cases, it will not be effective. So I would thank you very much for listening to this presentation, and I hope that you have learned some information that can help you treat your patients. Thank you very much.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/DNF. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.